this video, I'm going to be talking about the limitations of WHI study. I'll try to make it as simple as possible. WHI was one of the most influential studies in menopause medicine, but it has also important methodological and interpretative limitations. Many of these limitations explain why its findings were overgeneralized, over-exaggerated for populations for whom the data did not even apply, particularly the younger perimenopausal women. The comprehensive clinician-level summary of the key limitations are: number one, age of participants. That was the primary limitation. The mean age in the study was 63 years. Most participants were 60 to 79 years old. Many women were 10 to 20 years past menopause when hormone therapy was initiated. This is critical because cardiovascular and vascular biology differ dramatically between early menopause, which is less than 60 or 10 years since menopause, versus late postmenopause, which is greater than 60 years of age. Later analysis of WHI and other studies led to the timing hypothesis. The timing or healthy cell hypothesis suggests that hormone therapy started early in the perimenopause may be beneficial, whereas starting late may increase risk. So the population that they studied in WHI was not representative of typical hormone therapy users. At the time of the trial, most clinical hormone therapy users were symptomatic women in their 40s and 50s past menopause. They were older, often asymptomatic, and already had higher baseline cardiometabolic risk. So the study population did not really reflect the real-world hormone therapy uses. Next, the hormones that are used today were not the ones that were studied. WHI tested only one formulation for estrogen and one for progesterone, and that to just one dose. Estrogen, the one that they used, were conjugated equine estrogens at the dose of 0.625 milligrams, which was derived from pregnant horse urine. The progesterone that they used was medroxyprogesterone acetate, which is a synthetic progesterone. These differ from modern menopause therapy that commonly uses transdermal estradiol and micronized progesterone, which are both bioidentical. The medroxyprogesterone acetate, which was studied in WHI, has been associated with higher breast cancer risk, more adverse metabolic effects, and more pro-inflammatory activity. The WHI findings, that's why, cannot be directly extrapolated to modern regimens that we use today. The other factor was they only used oral estrogen. That was the only route of administration that they used. They only used exclusively the conjugated equine estrogen that I'm talking about at 0.625, only one dose. And we know that oral estrogen increases hepatic clotting factors, which increases the risk of stroke and clots. It also raises triglycerides. It alters CRP and inflammatory markers, whereas modern practices frequently use only transdermal estradiol, which avoids first-pass hepatic metabolism, which means that it completely escapes going through liver. It has lower risk of venous thromboembolism, which is clots in your legs and also in your lungs. And we use multiple doses, multiple variations, always choosing the lowest dose possible. Now, I've mentioned that they only studied single dose for both estrogen and progesterone, and both progesterone was also synthetic. There was no evaluation of lower doses, titration, or individualized dosing. It was just one dose used for everybody, blanket application. The titration was not done. It was not even based on symptoms. So that's not how we practice hormone replacement therapy today. The modern menopause care uses much lower physiological dosing and transdermal formulations, which I've talked about before. Then what came after was early termination of trial because the combined estrogen-progesterone arm was stopped early in 2002 because they saw increased cardiovascular events, increased breast cancer risk. It was stopped early, prematurely, because of the overestimation of the harms, and also and it did distort the risk estimation as well. It limited the long-term study of the outcomes. Later, the follow-up analysis showed very different risk patterns. This brings me to the discussion of relative risk versus absolute risk. They were also miscommunicated. It's hard for me to understand why there were so many flaws in this study. The media widely reported relative risk increase, which sound very dramatic. For example, there were 8 new cases of breast cancer for every 10,000 women, whereas the baseline risk is anywhere from 4 to 6 women per 10,000 women. So the relative increase is 26% if we did the relative risk, but absolute increase is small, from 4 to 6 per 10,000 to 8 per 10,000. So the actual difference is, even if we were to stretch it, 8 additional cases per 10,000 women per year. However, the public messaging and sensationalizing magnified the perceived risk. Then, adding to the confusion was that they did not report the estrogen-only arm. They only reported on combination therapy. The WHI had 2 separate trials, one that had estrogen and progesterone for women who had the uterus, and then estrogen-only arm in women who had had hysterectomy. There was an important distinction that estrogen-only arm had lower risk of heart disease and lower risk of breast cancer, which were never reported. This nuance was largely lost in the early reporting period. Then, talking about cardiovascular disease interpretation, the initial results suggested that there was an increased cardiovascular risk, but the subsequent analysis showed that women within 10 years of menopause or early perimenopause had neutral or even reduced cardiovascular risk. Later, WHI subgroup analysis was done, and that supported the timing or healthy cell hypothesis. What that essentially means is that estrogen may protect healthy vascular endothelium, but it is dangerous and destabilizing if the atherosclerosis is already advanced. So the older WHI participants most likely already had subclinical atherosclerosis, already had high cholesterol, already had high blood pressure, already had endothelial dysfunction. So we cannot extrapolate that interpretation to the women we are using HRT in now, which is early 40s. So, and at that age group, the baseline cardiovascular risk is already high. There was high prevalence of smoking at that time as well. That makes using that data to modern environment difficult and problematic. There was also problems with adherence and dropout issues in the study. The medication adherence declined significantly during the trial. Many women stopped the medication prematurely. Many women also crossed over between groups, like if somebody had hysterectomy for another reason and they went from estrogen only to estrogen progesterone therapy and vice versa. This reduces the strength of interpretation of data. Then there was also lack of individualized risk stratification. The trial did not stratify adequately by body mass index, by baseline metabolic risk, by family history, by individual risk factors, by genetic risks, even the symptoms of menopause and how severe they are. There was no stratification at all. The modern practices use individual risk stratification. It's more nuanced and more personalized. But what WHI actually changed in medicine is that it provided very important lessons for us. Number one, hormone therapy should not be used solely for chronic disease prevention. Age and timing of initiation matters. Therapy should be individualized. Individualized risks should be considered. These conclusions are now in the form of guidelines from the Menopause Society and American College of Obstetricians and Gynecologists. The conclusion or the current consensus in a simplified way is that for healthy women less than 60 years old, less than 10 years since menopause, with moderate to severe symptoms, can benefit for hormone replacement therapy. It is generally considered safe and effective. What matters is also the route of hormone therapy. The FDA-approved bioidentical hormones and transdermal estrogen or micronized progesterone is very safe and effective. Follow me for more questions and more discussion on this topic.